Good evening, everyone. I hope that I'm audible. Right. So I'm Tuarahan, and I would like to extend a warm welcome on behalf of the Rotaract Club of the University of Colombo, Faculty of Medicine. And yeah, I would like to welcome you all to the third session of the Friend in Need interactive workshop, which is a workshop on mental health and well-being conducted by the Rotaract Club of the University of Colombo, Faculty of Medicine, in collaboration with the Department of Psychiatry of our faculty. So today's topic will be the introduction to the Friend in Need workshop and its concepts and its objectives, along with common psychiatric disorders. And this will be conducted by none other than Dr. Chathurie Suraweera. I'm sure that most of you here would already be familiar with Dr. Chathurie. Probably from you all probably would have met her already in faculty or during our first session. So she's a consultant psychiatrist who's also a senior lecturer over here in the Faculty of Medicine, and she's also a past alumnus. And she's probably one of the best people in our country to talk about issues related to psychiatry. And she has done countless shows, countless seminars visible online, and countless talks about such pressing topics. You can even find it if you just search it up online. And today is going to be such something similar. So without further ado, I would like to hand it over to Madam. Madam, over to you.
Thank you. The objective behind it is like, most of us have stigma, discrimination against mental health issues and psychiatric disorders, and people don't seek help. And also we tend to take mental health for granted, and we don't treat it the same way as physical health issues. And that is another problem. And because of that, people are suffering silently, as well as there might be a huge impact on the academics. Like, for example, something that could have been prevented or something that could have been cured easily have gone for 2-3 years, and then ultimately they have to suffer in their academics, as well as sometimes, let's say it's a mental health issue like getting angry most of the time, then 2-3 relationships have gone down the drain because of the irritability. So those issues, if can be sorted out, then it would be really, really good for your career, for your progression, as well as for your studies and for your social family lives, and for relationships, for leisure and everything. And most of the time, we see that perhaps because you feel comfortable talking to your friends, and also your friends are the ones who are there around you, you're more comfortable telling them, as well as the friends observe if something is changing in the friends. And also, it's the friends who sometimes bring people with mental health issues to the services, as well as take care of them, because sometimes the patients or the friend in need is the person who is suffering is not hesitant to tell that to the parents or the carers. So in such situations, a friend plays a magnificent role. However, it's should be done carefully without getting too much involved, because the friend who is helping is also there to study and they have a life on their own. So you need to know where to draw the line, and you can't be like, guarding somebody who is having suicidal ideas. And that at that point, a professional as well as the family should come in and take the role, because you all can only initiate things, and you should not be held responsible, as well as you should not be taking the responsibility as well. You can be like, sort of working like the link between the one who is requiring help, the professionals, as well as the parents or the family. So This is kind of the objective from the psychiatry department point of view. And we thought it is when Nadun came and sort of gave us the idea that it's a great thing to do. And let's try it out and see whether how it's working. Because there are lots of people who are having mental health issues. You might not know, we know. Uh, so that's kind of like the objective. And Nadun, do you want to add something?
Yes, madam. Basically, the scope of our project is that means because as undergraduates, we are coming across and also ourselves going across many kind of psychological issues, and we feel that the all psychological issues are not addressed properly. So that means there are some people who are coming to counseling services, but there are a lot of like it is like an iceberg. So on the top of the iceberg, there will uh, some some issues are exposed, but underneath the water, there are a lot of issues that is not exposed. And if we can contribute ourselves as students to intervene, and ourselves could uh, help help as a whole to bring the mental well-being of ourselves together. That's the scope of our project, madam. And yeah, so basically, what we expect is to have a kind uh, of awareness about mental well-being and to collectively uplift the mental well-being among students.
Right. Okay. So I guess I'll go to the slides. So today, other than the objectives, we are going to sort of learn about mental health issues. So it's vast, and I know some of you have done done the mental health and psychiatry module, and some of you will be doing in June, and some have a long way to go. So that's okay. Just let's see what we can do. How do we at least recognize whether this is normal, abnormal, and what should we be? So don't worry about the number of slides. I won't be using all of them. Right. So let's sort of like, talk about psychiatric disorders and how we are going to sort of like, recognize it. Um, right. So now if we take diabetes, in diabetes, we know that there is an issue in the pancreas. So therefore, insulin is not there sufficiently. And also, even though insulin is there, it might not be working properly, which leads to high blood sugar levels. So then it get manifested as polyuria and polydipsia, like, there is increased frequency of passing of urine, and then you get thirsty. So those are the sort of like the symptoms. And then in order to get back on track, you have to take insulin or medications like metformin, and then you need to be monitoring, like with glucose strips. So that's what happens in diabetes. And if you don't do the proper monitoring and the medications, you end up getting neuropathies and nephropathies and so on. So your kidney might get affected, your nerves might get affected, your eyes might get affected. So that's what happens in diabetes. So when it comes to management of diabetes, there is exercise, non-pharmacological things, the diet. You need to monitor, you need to look for complications, and of course, you need to manage the disease, which is like by insulin or medications, oral hypoglycemics. So, when it comes to psychiatric disorders, that's also the same. There are certain areas in the brain, like the frontal cortex and so on. Not only it controls your movements and like, the tone and everything, but it also controls reward, pleasure, mood, and so on. So these are the areas, just like the pancreas, that your mood, behavior, how the thoughts are controlled. Memory, sleep. So there are specific areas in the brain. So although we tend to say hita tiyana tana danne na, where we don't know where the mind is and all sorts of things, it's an accumulation of all the functions of all the lobes. And see now, if you could see, this is an fMRI, functional MRI of a brain. So when you check the activity, the normal brain looks like this, but depressed brain is like this. See, you don't have to understand like what's going on, but you can appreciate the changes in the colors, which indicates that there is a change in the uptake. So this is what happens in the bipolar affective disorder. In schizophrenia, it's all orange and red. And when you have obsessive compulsive disorder, so there are changes happening when you check the functionality and reuptakes and so on. So keeping that in mind, psychiatric disorders are a set of symptoms or behavior associated in most cases with distress and interference with personal functions. But like let's say social deviance or conflicts alone without personal dysfunction is not included under psychiatric disorders. Now, let's say somebody is like a little bit odd, but it's not having an impact on that person or at the others, and then there is nothing happening, nothing harmful or dysfunctional about it, then that is not included under psychiatric disorders. So, what is important is in most cases there is distress and there is interference with personal functions. Now, if somebody scolds me, I might cry. Okay, by tomorrow I'm okay. But let's say if I'm crying like for months and months, and then I'm not doing any work, I'm like always at a side and not doing much and not sleeping, then there is an impact on my life, my functioning, as well as other people are also getting affected, because if I'm a housewife, I won't be cooking. I'm just there crying. So that is what is important. So at your level, let's say a behavior or the way that somebody is thinking or the way that somebody is feeling is having an impact on the lives of the others and an impact on that particular person, then there's an issue. Now, let's say some people, they get irritable and by about 1 hour or so, they're okay. But if a group mate, a, a batch mate is always fighting with others and saying inappropriate things and using filth, then it has an impact on the functionality of the whole batch or the clinical group. Then that means that person needs evaluation, assessment. So rule number 1, if there is an impact on the others and on this person's life because of the behavior, thoughts, or the way he or she is feeling, that's a place where a friend might want to be acting. And also, after talking or after thinking about it, that person might need to be referred to the appropriate places, at least to the mentor or to the to the professional somewhere. Because if that particular person is having a behavior or certain observations that are having an impact on that person and the others, that's beyond you guys. A friend who is in need cannot do that bit. What you can do is bridge to the parents or to the professionals or to the personal tutors. So now when we take norepinephrine, serotonin and dopamine, we think of blood pressure, heart rate and so on. But it's not only that. So anxiety, impulse control, irritability, mood. So those chemicals are present in the areas that I mentioned above. And not only the areas, these neurotransmitters are also responsible for how we feel, how we think, and how we behave. So, when we have a dysfunctional neurotransmitter system or an area in the brain, then just like when we are treating diabetes, you need to treat. And what are the outcomes? There would be a response. So the patient is at least improved by 50%. They would go into complete remission so that they are back to normal life. And then after some time, if there are exam or if there is something going on with his or her life, another depressive episode might come. And sometimes some people, because they have not taken the medication properly or they have not engaged in the psychological therapies properly, they might have this and that little symptoms like poor attention, concentration, and so on. So those are the outcomes of psychiatric disorders. So this is what I have mentioned here. Response is like, this is the baseline. So your mood goes down. So there is a certain level of improvement. If you go back to baseline, that's remission or recovery. And you can relapse as well. So see, I showed you this picture, but if we take depression as an example, you can have behavioral therapies. If that person is like in a corner, not doing anything, you can do something like behavioral activation, diet. For monitoring, you have to monitor the mental state examination and also by doing the relevant investigations. You'd have to look for complications like suicidal risk and so on. And you can give medications as well. So, depending on the abnormality that a person might have, and depending on where the issue is, these are the main psychiatric conditions that we need to think of and be alert about. There is depression, which is very common, schizophrenia, bipolar affective disorder, dementia, and anxiety disorders. These are quite common. So, just going beyond, let's say you pick up somebody and then you refer that patient to us. We need to make the diagnosis and we need to do the risk assessment and we need to build the supportive systems as well. Now, if there are good friends and if the suicidal risk is not so high, we might decide to send back to Blom or to Disserum. But if the risks are too high, we might admit or send the student home with the parents. And there are certain features like social anxiety, where like you're like really anxious about being scrutinized by others, and there's no real risk there unless there are complications. Then we don't have to do any of that. We don't have to tell anybody. So we just manage the social anxiety, social phobia. So there are conditions like that as well. Right. So this is actually what happens. So there is an acute management, intermediate management, and the long-term management, which is not your thing. So a friend in need do not have to do this. Just drawing the lines as to where to stop, because you need to know that as well. See, this is again another way, but you don't have to do any of this. Just the bridging, just the talking should be enough. So let's move on to depression, which is very important. So now, when you talk of signs and symptoms of depression, you might see that a particular person is always getting angry, intimidating, feeling sad, cornered, upset, not doing anything, have not studied, And there are features of lack of sleep all the time. So you might observe your friend is behaving this way. Or if it is you, I feel as if I'm not worthless, very sad, alone, as if everybody, I'm feeling useless, worthless. I can't study. I don't have energy to drag myself out of the bed, and I don't enjoy anything that I used to do. Scared. That's how I would be feeling, as opposed to what you would see in a person who is there, who is like sort of behaving in a strange way. So a bubbly person now is not like that. Now, withdrawing herself. Very happy person, now looking sad, looking down all the time. So what you see and how that person or how you will feel if that person is depressed, if I'm feeling depressed. So there are various things. It could be the exam stressors, it can be the genes, many things that might contribute to depression, which again, you don't have to worry about. So usually we diagnose a patient as having depression if there is depressed mood, loss of interest, reduced energy. So those criterion A are very, very important. You might see the self-harm and suicide are not major criteria. Those are not must, but this increases the risk if somebody is having self-harm or suicidal ideas. So if a person is depressed, if you think that this person is depressed, it's always good to ask whether there are suicidal ideas. People tend to think that it's bad to ask about it. No, that's wrong. They feel relieved if somebody asks you. So, do you think it's better to die? ඔන්න වාහනෙක්වත් හැපිලා මැරිලා යන්නේ නෑනේ. Or have they been searching ways to kill themselves? Those are very, very important. But leave aside the suicidal ideas. If they have lost appetite, they might not be eating, drinking. If they have lack of self-esteem, they might not study. They might not go for exams. So those are the things. Those are also risks. And they might fail exams because they have not been studying. Those are risks. And they might get angry and get into trouble. Those are risks. So those also you need to pay attention to. So there are various types, like, we have this entity of that a depressed person, it's like, will be aside and would not be talking, but some people are very agitated. Some people are very angry. So those ways are also there. So it would not be looking at this like this all the time. So now I'm going to stop sharing, and because I have told you the important things on depression, let's see, do you have any questions to ask? Because this is very, very common. Any questions? At least chat box, okay? Any person that you have come across?
I have a small question. Is there a difference between a depressive mood and depression?
Yes, there is. Very good question. So now let's say, now people, mood is how you feel. You might feel happy, you might be sad, you might be feeling angry, you might be feeling very scared. So that's the mood. Now let's say if a person scolds you, you would be feeling sad. So that's the depressed mood. Whereas the clinical entity of depression, the depressive disorder, needs to have the diagnostic criteria that I mentioned earlier. And only one of that is depressed mode. Now, out of the major criteria, depressed mode, persistent depressed mode, lack of energy, lack of interest in usual pleasurable activities, those are the major criteria. So how you ask is හැමතිස්සෙම දුක හිතනවාද හේතුවක් නැතුවත් දුක හිතනවාද එහෙම නැත්නම් ඇඟට පණ නැද්ද උදේට ඇඳෙන් එළියට එන්න බෑ බෑ වගේ කියලා හිතනවාද වෙනදා පොඩි මහන්සියකින් කරපු දේවල් වලට දැන් ගොඩක් මහන්සිද වෙනදා එන්ජොයි කරපු දේවල් දැන් කරන්න හිතෙන්නේ නැද්ද ඒව මහා නිකන් කරදරයක් වෙලාද those are the things and along with that නිින්ද යන්නේ නැහැ කන්න බෑ මැරෙන්න හිතෙනවා poor attention concentration. So all of the collection of these symptoms is the depressive disorder. Whereas ඔයගලන්ට consultant බෑන්නොතින් දුක හිතෙන එක that's a depressed mood. Okay, and just consultant බෑන්නම depressed වුණාට that is not depression either. That depressed mood has to be persistent. We say like over about 2 weeks at least. And the other criterions also should be there. Is that clear?
Yes, madam. And we are having another question in the chat box, madam.
Yeah.
Do they have to be on long-term therapy?
Well, it depends because now if it is the first episode, it's 6 months. We treat 6 to 9 months and then we can stop. If it is if there are 2 depressive episodes, then it's 2 years, and more than 2, then it's 5 years. So it's like that. So first episode, it's only 6 to 9 months. There's nothing called lifelong treatment with depression if you treat the first and the second episodes properly. So some friends, when they are in a low mode, become silent and stop communicating with others. How can we help? So, good question. Now, let's say boyfriend dumps you, you are low. And because when you are low and feeling sad, you don't feel like communicating with others and you become silent. That's the way they are. And that's how you do what you do and how you feel when you're sad, when something bad has happened. So that is actually a normal reaction to the breakup. But let's say, and certain people, this might be a repetitive pattern where, like, for about 1 or 2 hours, when they are upset, they communicate less and they don't talk to others. They are feeling low and something like that. But whereas some people, no matter what happens, they are upset, but they are able to keep a straight face and they interact with others and so on. So if something bad happens and you always go communicate less and feel sad for about hour or 2, or in some people 2 or 3 days, that's their predominant coping style. That's how they cope. Whereas some people, if something bad happens, they would be crying. They are like, talking to others, especially girls. That would last for 2-3 hours or 2-3 days or something like that. So that is ventilation and that is their predominant coping style. There is no illness there because how you check for illness is there a dysfunctioning happening on the part of the patient and on the part of the others. But let's say if that is going on for 2-3 weeks, and like usually when a boyfriend dumps you, you get what we call grief. It's almost as if like, somebody dies. So usual normal grief will last for about 6 months and it will resolve. And if it is going beyond that, and that's when you need to seek help. So as a coping style, if somebody goes into the corner and is like that, and that's a repetitive thing and it's happening almost daily, although there is no mental health issue, that coping is not very good because either that person is very sensitive and getting hurt by the slightest thing, or the person is reacting in an exaggerated manner. So, although there is no mental health issue, mental health disorder there, you might want to go for psychological therapies for to make themselves stronger, to make them less sensitive to those issues, and also to teach them and train them in better coping. Like හැමතිස්සෙම ඔහු මාසට යන්න එපා. Try enjoy, because that might shorten the duration of hiding and shorten the duration of feeling sad. So you give them better coping, like that. Does that help you?
Yes, madam.
Okay. Any other questions? Okay. Let's move on to the next one then. Now, when somebody is right. So bipolar affective disorder is where the person goes into two poles. There are certain times when there are very happy, very energetic than the baseline, and talking more, and they are taking up new projects and not sleeping, doing work in the night also. Like this. I'm not talking about happiness, the fact that you're feeling happy and you're feeling sad. That's not what I'm talking about. This is like for somebody to be called at least hypomanic, the symptoms should be there for 4 weeks and 4 days. And for somebody to be manic, the symptoms should be there for more than 1 month. So, and they go into depressive episodes that I mentioned earlier as well. I'll come to this question soon. Okay, I have seen this question. So, see now the baseline is this, and you get depressed, the lower pole, and mania. They get over talkative, very much energy, and like disinhibited, කොල්ල පස්සේ යනවා, වෙන්දට වඩා makeup දානවා, කෙල්ල පස්සේ යනවා. So, and hypomania, in mania there is violation of social boundaries. ගිහිල්ලා කෙල්ලන් අල්ලන්න ගිහිල්ලා හරි කිස් කරන්න ගිහිල්ලා හරි හොඳටම මේ සල්ලි වියදම් කරන්න ගිහිල්ලා හරි කැසිනෝ ගහන්න ගිහිල්ලා හරි there is violence and irritability, aggression. Hypomania is they are happy, they are very functional, but there is no violation of social norms. So that's hypomania. In both types, it's bipolar affective disorder. So there is elevated mood, increased energy in like by means of overactivity, over talkativeness, and self-expansive ideas. Mama hari lokkek mata araka puluwan meka puluwan e wage ewa. I have spoken about hypomania. There is, if you have mania, at least one episode, which is the severe form, it's bipolar 1. If it is less severe form, it's bipolar 2. And again, the neurotransmitters are implied there. So the important thing in bipolar affective disorder is that when a patient presents to us with the first depressive episode, we don't know whether this is going to end up as depressive disorder or bipolar affective disorder. So that's where some people come and say, මෙයාට මේ බෙහෙත් depression එකට බෙහෙත් කරන්න ගිහලා ලෙඩේ වැඩි වුණා කියලා කියන්නේ. Because when you are treating the depression, if that person is actually having bipolar affective disorder, there might be a manic or a hypomanic episode later on. And the risks are like, they might drive, if they ride bicycles, they might ride fast, and they would be quite reckless when they are driving, and they are like spending like nothing. So those are the risks. And they might be like a shy person, might be like suddenly over talkative with self-expansive ideas, and it would sort of alternate with depressive episodes as well. So, any questions that you need to ask about bipolar affective disorder? This is not as common as depression, but that's not to say that it's not there. No questions about bipolar affective disorder? Okay, now there's a question, how immediately should we act? So if you think that this person is having moderate or severe or depression, even without suicidal ideas, you need to refer that person. Okay, the only thing is, if that person is having suicidal ideas, you have to do the referring immediately. You have to involve an adult or a responsible person immediately. But if suicidal ideas are not there, perhaps you can wait till tomorrow. Okay, but still it needs interventions, at least tomorrow. Okay, but suicidal ideas are there, then you have to be very careful because you don't know when that might happen. So if you figure out suicidal ideas, passive suicidal ideas are there, then you need to act immediately. Hand it over to a responsible person. Don't take it upon yourself. But if there are not any suicidal ideas or anything, you can delay it for tomorrow or day after. But you don't have to take responsibility of depression or mania or something. Hand over. That's the best thing. Because in your capacity, I mean, what happens? Let's say somebody develops fever, you do the dengue testing and you hand over to the parents and to the hospital, right? Just like that. You figure out something is wrong, do the bridging part only. Is that clear?
Yes, madam. Yeah.
Right. Okay. So, if you don't have any issues with bipolar, let's move on to this. Now, schizophrenia is, you can't see, right, my screen?
No, madam.
Yeah, wait. So, schizophrenia is the worst mental illness that can acquire, but we have treatment for that as well, for schizophrenia. So, have you watched Beautiful Mind?
Yes, madam.
Right. Here, for those who are very new to psychiatry, these people have abnormal perceptions. And these people have abnormal beliefs. Now, let's say I suddenly start saying, too much batchmates are talking, and I start to say, these people are talking about me. So, without any adequate grounds, I come into a firm, fixed conviction. So that's what happens. I might say, my thoughts are known to the others. See, as soon as I think, somebody replies to that, which means my thoughts are known to the others. And I've been discussed on the TV. මේ කතා කරන්නේ මං ගැන. අර බලන්න මං ගැන කියනවා මෙහෙම මෙහෙම කියලා. So the thoughts are different. And this man is angry with me. This batch rep is really angry with me and he's plotting to kill me. So those are the thoughts. The thoughts are different. So, and they're abnormal thoughts. No basis at all, right? So that's schizophrenia. And also, now you could hear me talking, right? How many of you can hear me talking?
We can hear,
Another
madam.
We
Okay,
can hear you,
so
madam.
now without having this webinar, when you are in the BLOM, if you all start hearing my voice, obviously I'm not there at the BLOM, which means without me being there, you guys are hearing my voice, right? Unless there's a recording or something. So that's a hallucination. So now do you see this? What is this?
Marker pen.
Marker pen, yes.
It is a marker pen, yes. Now,
Ati.
how many of you can see the hands up those who see a pen? Nobody? Good, then you all are not having any visual hallucinations. Now, a person who is having visual hallucinations would see a pen here without this pen being there. Okay? Without me talking like this, while you're sleeping at BLOM, while you are awake at BLOM, lying on bed, you would hear my voice. So without a stimulus, you would be perceiving things. So the abnormal thoughts and abnormal perceptions are the hallmark of diagnosis of schizophrenia. And there they would get angry, they might talk weird things, sometimes you can't even understand what they are saying. So that's schizophrenia. Therefore, you need to refer. They also might be, depending on the problems that they also might have suicidal risks, harm to the others, not eating because they firmly believe that the food has been spiked or it's been poisoned. So they might not eat. And because I believe that the batch rep is trying to kill me, I might go and saw the guy. So those are the thoughts and the abnormalities that would be there. And sleep issues and so on. Definitely they need to be referred. And you might observe talk into self, smile into self. So that's something that you might observe. And some people might be really scared because they think that somebody is trying to kill them. So they're like scared, always cornered. So abnormal behaviors would be there. So that's schizophrenia for you. And this now schizophrenia is quite easy, but then I want to tell you something about morbid jealousy. Now, morbid jealousy is where, let's say I have a boyfriend. My boyfriend thinks that I'm going to leave him and I'm going to sort of start an affair with somebody else. So that guy is really suspicious, checking my phone. If I look at another guy, he would be like, අයියෝ අය කොල්ල දිහා බලන්න කියලා. රෑට clinical group එකේ කට්ටියත් එක්ක ඉන්න දෙන්නේ නැහැ. කොල්ලෙක් එක්ක කතා කරන්න දෙන්නේ නැහැ. Group mate කෙනෙක් ඉන්නවා මොනවා හරි group එකක mate කෙනෙක් ඉන්නවා නම් කොල්ලෙක් ඒකට කැමති නැහැ. So a lot of controlling behavior and suspiciousness that the girlfriend might or the boyfriend might go with another person. So that is morbid jealousy. ආදරේ නෙමෙයි. A lot of you guys tend to think යාළු වෙච්ච හැටියානේ යා මට හරි ආදරේ මට කවුරුවත් දිහා බලන්නවත් දෙන්නේ නැහැ. මාව හැමතිස්සෙම යන තැනට එනවා ෆෝන් එකක් චෙක් කරනවා. So මුල් කාලේක ආදරේ තමයි. පසු කාලිනව තමයි ඒක කෑදරේ වෙන්නේ. Right? So that is very, very important. It's quite common in Sri Lanka. Morbid jealousy. Any questions up to this point? No? Okay. Now, something important again. Let me share the screen. Now, if we meet with a threatening thing, like, if there is a threat, we get scared. So we get headaches, our pulse rate is racing, we might get short of breath, and we might be sweating, you feel like lump in the throat. That's what happens when you are scared and there is something threatening there. If these features are there all the time without a threat also, then that is called an anxiety disorder. So you're scared. It might be a specific thing like the exam. So exams කිට්ටු වෙනකොට හොඳටම බය වෙලා දැන් පාඩම් කරගන්නත් බැරි level එකකට යනවා. So that is anxiety. So that is a exam phobia. Hammathissema, you're like having these autonomic symptoms, headaches and all these things, and then sweating, worrying, being apprehensive, then that is generalized anxiety disorder. So that's there all the time. And then some people are scared of exams, some people are scared of makuluas, some people are scared of samanaleas, some people are scared of lifts. And if you can't go to the 5th floor in the tower, then it's going to be a problem. Even though it's a phobia, simple phobia, you need to get treatment for that. Because otherwise, you have to go up and down. And sometimes all of a sudden you panic. You feel sweaty, as if you're going to die, and you get increased heart rate. So panic attacks, they come and go. And if you're scared of making presentations, you avoid meeting new people, and you're like, there is anticipatory anxiety when there's a presentation close by. And after the presentation also, you're like, talking about it and like, having regrets about it. That's social anxiety disorder. So these are the anxiety disorders. Not so much of a risk, but then it makes you dysfunctional. It makes you really problematic. You might lose marks. And like, especially when you are doing clinicals, if you can't do it, perform in front of a consultant, fail, fail. Are you repeatedly washing your hands? Are you repeatedly checking the iron? Are you repeatedly checking the windows? And are there like, weird thoughts and images coming like sex, danger, and so on along those things? That's obsessive compulsive disorder. Basically, anxiety disorders. So this is also very common, and a lot of people might be having this. And if people have problems presenting histories, if you notice somebody trembling, there is an opportunity. There is an opportunity so that you can perhaps go and ask and help. Or if you are having it, go tell somebody so that you can get help for that. So those are basically the important things that you all will come across. And then there will be the other set where like I spoke to you about, like, anger. So if that is happening routinely, again, although it's not a mental health disorder, you might want to refer that person to somebody because that can't be හැම එකටම රණ්ඩු වෙලා පැන ගන්නවා නම් that can't be. And some people, if they're always withdrawn, තද වෙලා කොහේ හරි යනවා, goes missing, හැමෝම පන්දාගෙන හොයන්න ඕන නම්, again, although that person is not having depression, but there's a problem with their coping strategies. And the other important thing is alcohol and psychoactive substances. So alcohol, if they are using too much, if they are going for cannabis, ganja, KG, ice, even smoking, definitely somewhere that you can help. So that, because there are many ways that psychiatrists and psychologists help these people, if only they are detected. So that's very, very important. So those are the basic things that I wanted to highlight today, so that you all have an overview of what the important conditions that you might come across. So I know, like, the psychiatry is a vast subject, but these are the common things that might come and bother you yourselves, and these are common things that you might notice in others as well. So in my next session, I'll try and do certain role plays and case scenarios so you know how to tackle them and how to sort of talk to them to give some essential skills in that. Okay, open for questions. No questions?
Yeah, thank you, madam. If you have any questions, you can unmute and ask your questions directly from madam, or else you can put your questions to the chat box and we'll get those questions.
Madam, just one question. In
Mhm.
this specific phobia, that agoraphobia, is it? It is very confusing that the patients are scared of the open space, so crowds or leaving the crowd. Or what is going on with that specific phobia, madam?
Yeah. In agoraphobia, what happens is they are scared of open spaces. So because when it's open, like it opens into like, somewhere, and then they feel trapped because of that. So they are scared that they might not be able to escape. For example, you're in a queue and you know that you need to sort of move forwards in the queue. You feel trapped in the queue. And agoraphobic patients in a bus, they would be seated or standing right at the exit. So when they feel trapped, they just escape from the nearest exit. Okay. And like, let's say the person is in the supermarket, it's an open space, but they feel trapped within that space. So in crowds, in open spaces, they feel trapped. There is no, unlike in claustrophobia, it's not a closed space, it's open, but within the openness, they are trapped. They feel as if they can't escape. So like in the queue, they are trapped. ඒකින් escape වෙන්න බෑ. දැන් ඒකෙම ඉන්න ඕන වගේ කියලා. බස් එක ඇතුලේ බස් එකකින් what they do is අර බය වුණාම ළඟම තියෙන මේවකින් they feel trapped, so they get out of the bus like that. Is that clear?
Yes, madam. Thank you.
Also, madam, I just wanted to ask about bipolar disorder. So I actually didn't know uh, I used to confuse it with multiple personality disorder. So I got some sort of clarification today, but how exactly is that
Bipolar
different?
affective
'Cause-
disorder is like the mood symptoms. It's a mood disorder where in bipolar disorder, like when you're happy, you are loud, you are energetic, you do things. It's how you act, right? So when that is persistent in excessive manner, that is a manic or a hypomanic episode. And at the same time, when you're sad, you're like sad, you don't feel like doing anything, so depressed. So that alternates. Multiple personality disorder is something totally different. It's very rare in Sri Lanka, and it's a conversion disorder. What happens is, let's say now I'm a very timid and shy person and I'm getting bullied by other people. So I kind of, without me knowing, inside me, by my mind, it creates another person who is another stronger personality who can combat these people. So that I'm a very shy person. මට ඉතින් හැමෝම ඇවිල්ලා බුලි කර යනවා. මම දන්නේම නැතුව because I'm so much in distress, my mind creates this person. It is me. But let's name this person like Malani. Malani is like ඕන එක්කටම බයිනවා, ඕන එක්කෙනෙකුට ගහ ගන්න යනවා, ඒ වගේ එක්කෙනෙක්. So it sort of alternates the different personalities. Do you get what I'm saying?
Yes, ma'am. Yeah.
And the person doesn't really know because mind is kind of like playing a trick there. Okay, but in bipolar affective disorder, those are persistent, and like, the person knows I'm feeling sad, the person knows I'm feeling happy, and so on. You wouldn't come across multiple MPDs much. It's only like, have you read Sidney Sheldon's book?
No, madam, not really.
Okay, we didn't see that's exactly what happens there.
Right.
Excuse me, madam.
Yes.
Can you somewhat explain about the borderline personality disorder?
Okay. Borderline personality disorder is the type of personality. Now, let's say, like we all have certain types of personalities, and that personality might be good, might be harmful to the person as well as to the others. For example, now let's say like ඔය පාතාලේ ඉන්න මිනිස්සු ඒගොල්ලන්ට මරන්න බය නෑ, සතුන්ට හානි කරන්න බය නෑ. ඒගොල්ලෝ like repeatedly දෙවනි ගෙදර වගේ prison එකට යනවා එනවා. So that's the kind of people they are. The personality is antisocial personality disorder. No remorse, no regrets, frequent confrontations with the law, and multiple psychoactive substance abuses, and so on. Just like, and there is an impact to that person as well as to the community and to the others. In emotionally unstable personality disorder or borderline, what happens is multiple relationships, they are very intense, short lasting, repeated deliberate self-harm. There are predominant coping ways like deliberate self-harm. Their mood fluctuates, like it's like මෙහෙම fluctuate වෙනවා මේ පැය එක නෙමෙයි ඊළඟ පැය ඕ මේ දවස් එක නෙමෙයි ඊළඟ දවසේ, and they feel this emptiness, and they're very impulsive. බඩු පොළොවේ ගහනවා, මිනිසුන්ට කරදර කරනවා. So there is harm to the person as well as to the others. So that's borderline personality disorder. It is there in Sri Lanka. හොඳ තරමට තියෙනවා.
Thank you, madam.
Frequent relationships, break up උනායින් පස්සේ ඉතින් අනිත් මනුස්සයට ඉන්න දෙන්නෙම නෑ, පිටිපස්සේ යනවා. That's how, because they don't like, they have what we call rejection sensitivity. They don't like to get rejected. Any other questions? Okay, then that's it from me for today. Thank you.
Thank you, madam.
Right.
Thank you.
Thanks again, madam. And also thank you everyone for joining in and sticking till the end. So once again, thanks again to madam for the really wonderful session, and we honestly hope that you found it really useful. So we'll keep you all informed about the next session in the WhatsApp group. It will be held throughout the rest of this week in the same time, 5 to 6 p.m. So please stay tuned there. Thanks again for joining, and have a nice day.